Steve Charles in Memphis, Tennessee at Hamilton Eye Institute. Today is a vitreomacular syndrome with a large cystic space macula. The patient has 1+ nuclear sclerosis, which will not inhibit the view. But while I'm on that subject, if the patients have 1 or 2+ nuclear sclerosis, then I always do the vitrectomy surgery first. If there's 3 to 4+ nuclear sclerosis or subcapsular cataract, I recommend the cataract surgery first, but it's very important to use optical means to measure coherence to measure from the pigment epithelium to get the axial length, as opposed to a scan, which will have an incorrect axial length shortened by the elevation of the macula. With vitreomacular traction syndrome, it's important to, in my view, peel the ILM. Staining is absolutely essential. We didn't even know this disorder existed practically until we had OCT. So in the operating room, although endoilluminator makes your view somewhat better, you still can't see. Many doctors use a triamcinolone for particulate marking of the vitreous. I don't have a problem with that. I don't do that, but I never use a chandelier. I use focal endoillumination so I can see the posterior vitreous cortex better, and I'm very happy with that technique, although I have no problem with those who choose to use the triamcinolone, and they should use the preservative fee like triesence if they can. So with respect to the posterior vitreous separation from the macula, obviously this is essential, but you can do this slowly and carefully if you use the cutter and use scissors, and use forceps to peel ILM. One of the questions is how much peripheral vitrectomy to do. Some surgeons believe you need to shave the vitreous in every single case. I think that's ridiculous, and it's commonly done all around the world, and I don't do that. So things that I see commonly done when I travel around the world and operate in different places and attend meetings is, one, phaco-vit in everybody, and the refractive outcomes of phaco-vit are terrible, and I do not approve of that approach. I've already mentioned how I do lens management. The other thing that I see people do is this tedious peripheral vitreous shaving before they even pay attention to the macula. If you have any lens changes at all, posterior capsular lens changes, those can get worse while you're dealing with periphery, and there's simply no need to shave vitreous down to the retinal surface in patients that are having macular surgery. So I do a core vitrectomy, take a careful look at the periphery with wide angle visualization to make sure that we didn't make a retinal break or one's not already present that we somehow missed in the office. Operating times are typically 15 minutes. We never use general anesthesia unless the patient's a child or is, of course, claustrophobic. So local anesthesia is quite adequate in these patients. With the Ingenuity system, which we use on every case, and I strongly prefer visualization with the Ingenuity system, you've got to keep the screen 42 inches away, which is 1.2 meters. This is absolutely essential to avoid accommodative convergence conflict, as well as to match pixel size to viewing distance. The aperture should be set at 1/3 or 30%. Why? That gives you the 4.5x greater depth of field, which is one of the principal advantages. So the advantages are greater depth of field and greater magnification. There's some more subtle advantages. Now notice that I'm at a 30-degree angle and I displace the conjunctiva, and I'm maintaining that angle without putting any forceps on the globe, which is essential. Can we irrigate right there? Let me have the bishops, please. Thank you. These are valve cannulas. Some people put all 3 in and then put the infusion into the first one. I don't like that idea because if the eye is somewhat soft, you're not doing as good the adequate job of penetrating the non-pigmented ciliary epithelium and choroid when you insert. So we always tape the infusion cannula with the service lift. It's kind of tilted up, as you can kind of see here. Why do you want it tilted up? If you're going to do fluid air exchange, your pseudophakic eye, if it's tilted down, what will happen is you'll see an air bubble in the anterior chamber whenever you go to fluid air exchange. So once again, displace the conjunctiva so the conjunctival incision is displaced relative to the sclerotomy. Then hold this finger on the other hand here to guide it. No need to grab the eye with forceps or anything like that. We never scrape the corneal epithelium, probably once a year. And we use balanced salt rather than viscoelastic on the cornea. And I always use contact-based visualization. Why do I use that instead of non-contact visualization like the biome or ReSight? I do that because it eliminates all corneal asphericity, which is obviously quite common. RK, LRI, just native irregular corneal astigmatism, form frust, keratoconus, corneal sclera, previous pterygium removal, previous corneal laceration. There's so many reasons. Corneal asphericity rather. We always want to zoom up like so. We need to make the light a little dimmer, the illumination. I never pull back the cutter while cutting. I always hold it and sort of cut free before I move. And I use the end illuminator to see the vitreous going in the port, which I'm kind of illustrating here. You can see some movement of the retinal surface because the vitreous, of course, is attached to the retinal surface. Okay, let's use wide-angle visualization and do some peripheral vitrectomy. And we'll check that again after we lift off the posterior vitreous cortex. The basic principle of vitreous is don't pull it in centrally, and that's what I'm trying to do now, as you can see. Okay, let's go back to the flat contact, and then we'll, so uninvert, please. There it is. So you can see a change in retinal contour. I never move side to side when I'm making a PVD. So you can see kind of a white ring being created. Try to pull straight back to avoid a vector, force vector on the periphery. Now we'll check again. Carefully watching toward the macula. Let's go over this way. Okay, we don't want to unroof assist. Good, we've got a nice lift of the vitreous over the macula. That's exactly what we wanted. Carefully peeling vitreous away from the macular surface, watching macular contour to make sure we're not unroofing that macular cyst, and it's going well. Okay, let's go over here. Okay, let's put the wide angle on and look around the periphery one time, just carefully, since we made a PVD. Okay. Just want to really make sure we got. Did I post the FGX or no?
Yeah.
Okay. So the point of what I'm doing is not so much peripheral vitreous shading. It's about inspecting the periphery. Okay, so let's go back to. But the 3 cc syringe is essential because it allows you to inject at 1/3 the velocity, and it allows you to have 1/3 the stiction force, so you can have a very controlled injection. Whether you inject with a tuberculin syringe, the throw of your finger, your second digit to operate the syringe is very long, and it's very hard to hold still. And we'll need less light when I do the membrane peeling. My scope won't move in that direction because of where it. Well, I'll do the best I can. It's just, I can't move it up. I'll take this ILM out. I think we peeled sufficient margin. So let's do fluid air. I often do vitrectomy under air. I saw a little strand of vitreous there and resected it. Great way to see if there's residual vitreous. Obviously crucial in a retinal attachment case, not likely an issue here. I always press on the scleral tunnel as I pull it out, much as if you're taking an IV out of somebody's arm, and that closes the scleral tunnel. So let's pull a port and then we'll do air gas exchange. So once again, I'm going to press on the scleral tunnel. Well, I'm going to press again. Got a little subconj. Remember, the pressure is higher than usual. With ILM peeling, obviously, a non-moving patient is crucial, and a stable hand position is crucial. Because there was patient movement exactly as I approached the retina, there was a little contact, no retinal break. That's why you saw a little spot of retinal whitening. Won't hurt anything. I'm a perfectionist and things like that. Can, you know, make me unhappy, but in fact do not affect outcomes. So, but it's far better if you don't do that. So in this case, what did we learn? We learned that it was possible to safely create a PVD very slowly and carefully without unroofing the MAC cyst. And then we learned that we had to peel this tissue off the retinal surface, which was nearly invisible until the brilliant blue stain. And then I peeled that 360 around the macula, and now we know the macula will go back where it belongs. It's probably overkill to use a gas bubble. Others don't do that in purely vitreomacular traction syndrome cases. But this patient will position well, is very bright, in fact, and will do what we said. And I think it may add a little bit in the success rate. I'm opposed to the use of air in full thickness macular holes. It simply doesn't have the same closure rate. When people make this statement, with my technique, and again, referring to macular hole surgery, positioning isn't necessary. It's really not the case. It's some, I don't know why people make such a huge big deal about it. If you lay on your back for 1 week after macular hole surgery, not one hole is going to close. So in fact, everybody positions by saying, don't lay on your back full time for a week. If you are phakic and you lay on your back, you get a gas cataract immediately in most patients. Sometimes if the anterior vitreous cortex is completely intact, you won't get a gas cataract when you lay on your back, but you won't close the hole. So if the patient is pseudophakic, we can say, sit up, walk around, walk on a treadmill, go to the gym. No need to tip your chin forward. But if they're phakic, I tell them just keep your chin down like you would anyhow to eat or to look at a laptop on a table or fix a watch. And I tell them, of course, it's better not to drive a car even though they have perfect vision in the other eye because they're not used to having one eye blocked by the gas bubble. And we don't let anybody fly in an airplane until the gas bubble's essentially gone. Because we used to have this, if it's 10 or 15%, it's okay, but we've heard instances where the patient had pain and the pressure was very high. Back to ILM peeling. When you peel the ILM, it's important, obviously, to start not in some standardized location, but to peel the ILM wherever your hand is most comfortable. Instead of saying, you always start supratemporal, always start supranasal, or start near the arcades, I don't buy that. Start where your hand's comfortable and where the staining is the best, and you can best see what you're doing. I always double stain only with brilliant blue. So when I put the brilliant blue in, if there's an epiretinal membrane, it of course doesn't stain the ILM very well, or kind of patchwork kind of matter. And then I begin to peel away the epiretinal membrane first. Then with brilliant blue, you can stain multiple times, and I always do. So once you've peeled off posterior vitreous cortex, stain again with brilliant blue. Once you peeled off epiretinal membrane, still stain again with brilliant blue. And then to make sure you got all the ILM, you can even stain another time. You simply can't do that with ICG, and I don't use ICG because it's toxic. I know that many surgeons, well over half in the United States, use ICG and quote unquote get away with it. I've seen a few cases of ICG toxicity, but again, these people are very careful about concentrations for good reason and about exposure time. And I've only heard of 1 or 2 doctors that would even consider restaining with ICG. The most important thing with all of membrane peeling, in fact, all of vitrectomy, is you operate quickly by being efficient and not wasting time by not thinking through upcoming steps. You can't say, would you get the laser? Well, hold on, it's down the hall. We'll be here in 10 minutes. We got to go get it. plan ahead. Think through all the steps you might need. Don't open up expensive things that you might not need and waste money, but have them readily available in the operating room. And think several moves ahead, like apparently great chess players do. But it's not about your hand moving rapidly. To improve your dexterity, what you should practice is to move your hand as slowly as you possibly can. Practice that not just with forceps and scissors. Practice it when you're injecting PFO. Practice it when you're injecting brilliant blue. Practicing when you're using your endo laser. So one of the things when I watch young people operate that are just getting started and frankly not doing a very good job is the instruments move too rapidly inside the eye with respect to approach to the retinal surface. There's almost a fear factor associated with ILM peeling that kind of makes people do it abruptly. That's exactly what I don't want to do. I want to move my hand as slowly as possible. I think this is an essential step. With respect to diabetic traction detachments, for example, let's talk about that for just a moment. When I hear people say scissors are no longer necessary, I simply do not buy that argument. I use scissors for every tabletop traction detachment. Anytime that membrane is close to the macula or over the macula, anytime there's tight adherence. Membrane peeling is seldom possible in the diabetic traction detachment context. Sometimes if it's very recent, you can lift, but instead of starting with the notion, I'm going to peel and only go to cutter and scissors if necessary, start with the notion, I'm going to do what I can do safely with these beveled cutters and with cutter delamination, either fold back delamination or conformal. Conformal means like this, and fold back means like that. Or let me raise my hand. This is fold back, this being the membrane, this being the cutter port. And this is conformal, feeding it in like so. That's the best way to approach such patients. And then, but if you're at all concerned that you're going to make a retinal break with the cutter, and just say, instead of saying, oh, it's a difficult case, therefore I put in oil, what you should do at that stage in time is to move to scissors delamination, always with the curved scissors, usually an inside-out orientation. In the diabetic patients that we operate, it's, in my view, if there's not a sufficient PRP, patients that had enough proliferative retinopathy to require a vitrectomy should have PRP completion. With this caveat, do not treat areas of TRD, even if you acutely attach them in the operating room. There's always subretinal fluid left. The retina is often edematous, and there's a real tendency toward overtreatment, which can result in fibrin syndrome and reproliferation on the retinal surface if you PRP an area that's had a traction detachment. I always inject Avastin at the end. If there's any active neovascularization preoperatively, we inject Avastin preoperatively within a week of surgery. This fear of the so-called crunch syndrome of rapid cicatrization has caused people to give up preoperative Avastin, which is a huge mistake. It's far better to inject it and then operate within a week. But remember, you've removed all the Avastin at the time of surgery, as Stanley Chang points out, so you've got to put Avastin in again at the end of the case. So this is a major step. I will now describe what we're going to do in the next patient. The next patient has diabetic retinopathy, proliferative retinopathy with a vitreous hemorrhage and an epiretinal membrane. So in this case, there's really not traction detachment. Therefore, we will be able to peel membrane. Invariably, if I peel membrane, then stain with brilliant blue and peel the ILM. As I mentioned earlier, if the PRP is not relatively confluent, we'll do a light PRP. I don't use the repeat mode when I do endo laser. Most folks do. Why am I opposed to repeat mode? Because I've seen people that treated the fovea that way by getting in a pattern of going left to right, top to bottom, sort of the Western way like you read. And with that repeat mode, just going back and forth and kind of losing their spatial orientation and lasering the fovea. Not a good thing. So I want to volitionally, most of these patients have some intraretinal hemorrhage. Many of these patients that had prior laser, well, you don't want to put a spot at any of those locations. You're not, so why have a repetitive laser mode just to keep from tiring your foot out? So I strongly urge people to use continuous instead of pulse laser and repetitive laser, and volitionally treat each spot. If it's lightly pigmented, you need more energy. If it's heavily pigmented, you need less energy. If you're going to, and then it's very important to focally treat any area of neovascularization. You can even treat elevated neovascularization on the disc with laser, but not with diathermy. Have promoted heavily the use of endo laser for hemostasis, not just endo laser for panretinal photocoagulation. This is a very important principle. Why? Years ago, I did thousands upon thousands of traction detachments, and because that was sort of catching on, I took many post-operative photographs. And a year or two, or sometimes 3 years later, I'd see large round holes that weren't present 6 months out develop in the posterior pole. So the conventional explanation for that was, oh, it's atrophic or it's ischemic. And I said, well, wait a minute, why do we not see that in the non-operated patients? So I traced back their records. In every instance, it was a location where I had applied diathermy for coagulation. When you use diathermy, it's indiscriminate. It makes coagulative necrosis of everything within the radiofrequency energy field, unlike endophotocoagulation. So endophotocoagulation is far better for hemostasis, particularly on the optic nerve head or along the arcades. Why? Because the 532 nanometer, in other words, green laser energy is confined, the absorption is confined to the hemoglobin blood column. So it only coagulates that part, and unless you turn the power up too high and the duration way too long, it doesn't treat the areas away from that vessel. So again, I use continuous, and I hold down the pedal until I get sufficient response. Be careful about using short duration because the vessel will go into spasm. You'll think it's coagulated when it's not. So that's an important thing to keep in mind. In using hemostasis, typically in the diabetic traction attachment or proliferative retinopathy context. What about peripheral vitreous shaving in these cases? Many surgeons go immediately to wide angle visualization when they're doing a diabetic traction attachment, for example, or a vitreous hemorrhage. I think it's far better to use higher magnification and a flat contact lens and do most of it that way. And only if the traction detachment extends out to the equator do you use the wide for the basic elements of surgery. The notion that you need to do PRP anterior to the equator is complete nonsense. Some programs have pushed that for years. That retina is all perfused from the coronal side because the partial pressure of oxygen in the vessels, the saturation is virtually nothing way out in the periphery. So the far peripheral retina, you don't want it to you don't want it to be detached because it'll create VEGF. So I'm not saying it's okay to let it be detached, but remember it gets its oxygenation primarily from the coronal capillaries. So trying to PRP anterior to the equator is nonsensical, and it results in phakic eyes and people bumping the lens. Let's come back to the lens for a minute. This emphasis on phaco-vit I see worldwide should be coupled with an emphasis on better refractive outcomes. I've talked to many vitreoretinal surgeons around the world, operated in 25 countries, and it's interesting to me that people do phaco-vit, and I say, do you use toric lenses? No, never did that. What formulas do you use? Do you know Graham Barrett, Warren Hill, the RBF formula, Doug Koch, Art Cummings? Never heard of any of that. Do you use intraoperative aberrometry? No, I don't. So I like to see a push if people feel compelled to always take out the lens to get better refractive outcomes, which patients have come to expect today. But there's another story. Does vitrectomy cause cataract? Rhetorical question. Does vitrectomy cause cataract? It does not. It causes nuclear sclerosis progression. If you're 20-year-old diabetic and you have a vitrectomy, 20 years later, your lens is often clear. The idea that you must take the lens in a 20-year-old or a 25-year-old diabetic or a foreign body case or macular surgery because they're going to get a cataract is simply fallacious, and it's been stated on the podium 1,000 times. If you've got 1+ nuclear sclerosis, you're 47 years old, and you have a vitrectomy, no question, 3, 4, 5 months, not 12, you're going to get phaco. And instead of combining the procedures, I prefer to get the retina fixed, let the eye become uninflamed, it's so-called quiet, and let a cataract surgeon do a great job with cataract surgery later. Now, if the economics, the logistics, travel, etc., socioeconomic issues drive a combined procedure, then let's amp up the emphasis and get refractive outcomes where they need to be, like standard cataract surgery patients, instead of using, you know, K's and A's and getting in one formula and getting very average refractive outcomes. It's tough enough to get good refractive outcomes if you measure with multiple machines. In the presence of a vitreous hemorrhage, how do you measure optically? Well, you can't. So now you got to use A-scan. Well, what if the macula is elevated? Well, then you don't know the axial length. These are serious issues that need to be considered to get better outcomes. Anesthesia-wise, in some parts of the world, general anesthesia is used quite a bit. I've heard the excuse, well, the operations take too long. That's not an excuse to put the patient under general. General anesthesia in great hands the patients do very well. On the other hand, it does add risk. So at any rate, with local anesthesia, there are certain things that I think are important. One is we want to do minimal sedation, and then we use typically Versed just during the block. But what kind of block? We use a 27 1 1/4 sharp needle. Never use retrobulbar needles. The late Sandra Kazard, the Ophthalmic Anesthesia Society, all of them emphasize the 27 1 1/4 sharp and straight in trajectory into the muscle cone. You start at the outer corner of the orbit, out here, not this 1/3, 2/3 of the lower lid situation, and aim for the muscle cone and a straight in trajectory. It's been shown in the interventional radiology world that once a needle enters tissue, your attempt to steer it is zero. So straight in path, aim for a point halfway between the orbital apex and the optic nerve head. Have the nurse hold the eyelid open as far as possible so you can visualize the equator of the eye and keep your bearings, because you're trying to do an intraconal injection, the proper name for a retrobulbar block. I never use wide A's. It's half the studies in the peer-reviewed literature show it only changes the onset by 45 seconds. It doesn't change the effectiveness of the block. And I don't use epinephrine. We have enough patients with tachyarrhythmias and ectopic beats without it, so I don't use any adrenaline. And if you mix it 50-50 with Marcaine, each drug has half the concentration, so I don't do that either. But the operating times are never over an hour, and 2% xylocaine is adequate for that. It is possible to reblock during the procedure. I've done that a handful of times, usually when we stayed a little too lateral during the block and didn't sufficiently block the nasal part of the orbit. This last patient had a little pain when the nasal cannula went in. The block could have been, and the medial rectus was functioning a little bit during surgery, so the block could have been a little more nasal. But again, it's natural to be cautious to not perforate the globe. When you do local anesthesia, it's essential to put a vacuum line under the drape, because when patients say, I can't breathe, I want more oxygen, what they're telling you is that they have the hypercapnia, that they have a rise in their CO2 levels. So the conjunctivis displaced, so its opening will not be aligned with the scleral opening. There's no need for me to measure, because I've done it so many times, but I urge you to measure with a caliper. So I'm trying to go in at a constant 30-degree angle, not a biplanar. I steer with this finger on the other hand, as you can see. Let me zoom out just a little bit, show you what I mean. Well, it's already zoomed out. So now let me have the bishop. Although these are relatively self-retaining, I find it better to make sure you don't pull it out even the slightest bit. By it, I mean the cannula when you, somebody had the infusion, thank you. And you gotta snap this into the detent. Partial pull out of the infusion cannula has been a major problem, and people think, oh, the machine, the infusion failed, or the patient got a choroidal. No, you infused in the choroid. It's a very common and can be quite a serious problem. It is manageable if you catch it early and do it right, but it's far better to prevent it. So taping, once again, conjunctival displacement and pelvis conj on the sclera. Put this finger forward from the other hand, as you see. preserve the angle or the pose relative to the sclera. You want to be always limbus parallel. Thank you, Dr. Berger. Conjunctival displacement. And obviously, you want to make a radial incision because you're building a scleral tunnel. These two temporal ports need to be just above and below the horizontal meridian. People say, what hour of the clock? This isn't about telling time. The hour of the clock doesn't matter. This is about orbital anatomy. So where should the nasal one go? That one should be on a line between the lowest point of the bridge of the nose and the pupillary axis. Why? That allows you the greatest angular access anteriorly. And if these just straddle the horizontal meridian, I could even have made them slightly closer. That allows you better orbital access. If you start making this incision up here, what happens is the supraorbital rim interferes with your internal access. That's also why I snapped the handle off the back of the Ultravit, because I want to be able to treat it like a ball joint. So let's turn the light way down. There we go. Zoom up. Light's too bright still.
Light.
So as I said, minimal amount of vitreous hemorrhage, but largely about an epiretinal membrane in areas requiring focal treatment. If you treat within arcades, like you would with Pascal and similar lasers in the office, you want to use short duration. We need a straight laser probe and brilliant blue, and ILM forceps will need.
We just making sure we have
Rhetorical question. So are you going to peripheral vitreous shave in this patient? Why? It's not a retinal attachment. Vitreous hemorrhage is mostly settled at the bottom. We want to get that out. Okay, let's go to wide so we can get that inferior vitreous hemorrhage. The depth of field is so great, you can see the capsulotomy and the peripheral retina at the same time, roughly in focus. Always 10,000 cuts per minute. Never use 3D or dual linear. You always want to use proportional vacuum. The pedal has up-down travel to control vacuum for a reason. Use it. The idea that you should adjust the level at the console and then always put the pedal all the way down makes absolutely no sense. Having multiple presets for core and shave and posterior and anterior and all that, I simply don't get it. I use proportional vacuum for all. And if there's too much vacuum, I don't push the pedal down as far. So instead of all these complicated modes that I don't think are actually very well understood, that make the procedure take longer and be harder to learn, just really use the bandwidth of the pedal and don't push the pedal down all the way if there's too much vacuum. Even with highly mobile retina, very rarely just barely touch the foot pedal. Just like you would in your car, you don't startle the people across the street when you enter the living room. All right, let's put some blue on and see if we need to peel from OCT. We do. Thank you. We got wide, so we need to invert. I mean, we got flat. Yeah, thank you. And we'll have to come down a little bit. All right. So how fast do we inject the brilliant blue? Slow. Wide, so we don't make a stream. Wallace Folds in Glasgow and the late Robert Mockhammer invented the retinal attachment models that people use in the laboratory. How do they do that? They shoot a jet of fluid at the retina. Well, we don't want a jet of ICG or brilliant blue or anything else underneath the retina. So inject slowly. How to do that? 3 cc syringe and practice. Slow is good. So let it sit there and stain for a while. We jokingly call it marinating. And we'll have to turn the light up a little bit this stage. Remember that your eye has 10 to the 7th dynamic range, whereas camera heads and displays have about 10 to the 3, 10 to the 4. So that you have to adjust light levels more. Small price to pay for having 1/5 the light exposure. I typically have the light set on 2 or 3 during membrane surgery, macular surgery, where before it used to be 10 or 12 on the constellation. By that number, I mean percent on the constellation. So when we take the blue out, we'll be able to turn the light down a little bit. If you're not sure the first time, but you think you're going to have to peel, stain the second time. So let's go to the disc and see if there was a PVD. We turn the light down, please. So vacuum only over the optic nerve head margins, pulling straight back. Usually when there's a vitreous hemorrhage, a PVD has occurred. There's a little vitreous right there. Do I know yet if there's a PVD? I don't. That's why I'm checking. Because there wasn't impressive staining. So there's a little cuff of it left right there. But the retina contour is not changing when I move like this. And I'm at max back 650. And so it's not engaging vitreous. Therefore, a PVD was present. So you can see the cystic spaces in the macula, but I'm going to stain again because the staining is not dramatic. One cause of minimal staining is residual vitreous or membrane. So we ruled out the residual vitreous, so let's stain again, leave it a little longer this time. Can't do that with ICG, as I said. Or shouldn't do it. All right. It's hard to be patient, but it's the right thing to do at this stage. This foot pedal is so close to me. There. No, it's better. Okay, there's a little staining, not a lot. It's always in the light colored fundus, it's harder to see with brilliant blue. Of course, ICT is a more intense stain, but as I've said many times, somewhat toxic. Although many real good surgeons still use it, but short exposure time, low concentrations. The patient has rather significant respiratory movements. I'm trying to time my ILM peel with when the head moves back and forth. Try to stay awake, sir. I'm being real careful. I always am, but there's a lot of vertical motion from the patient's breathing, so I'm having to compensate for that. Now you can, of course, see the need to peel. Up and there's both movement along the patient's long axis, so to speak. Okay, so sit if I can.
Yes.
Cutter in my left hand. Well, let me see here. No, let me just have the cutter in my right hand. With valve cannulas, a membrane like that, you can't, we just invert it. I might have done it with my foot pal. That membrane go. So anyway, with valve cannulas, a membrane like fairly sizable one like I just removed is going to get trapped in the cannula. So this little piece right here is well away from the macula, and there's no point in adding risk by peeling that. And so I got rid of it. So now let's go with the laser. And remember, you can focally treat neovascularization. Not only could, you should, in a vitrectomy context, because you don't have to worry about contraction of the posterior vitreous cortex. In the office, most people are taught not to focally treat. Aiming beam is too bright, and the white light is not bright enough. Back down a little bit. No, a little bit up with the aiming beam. Sorry, we have to fine tune this one. There we go. Laser filters in, right? So let's see where the macula is, make sure we're in the right place. And patient movement. Patient movement's making this a bit of a challenge. Nice. Sorry. Center of the lens, yeah. You know what? I don't think I'm going to do a big PRP. I think he needs it. Exactly. So by combining focal treatment to these areas with Avastin at the end, we can avoid having a giant PRP, which could contribute to macular edema as well as some night vision issues and loss of peripheral field. So the combining of discrete focal laser like this, just kind of check to make sure I didn't miss anything. I think we can do IVA now.
Yes, sir.
And that's it. So now we're going to do Avastin. So I'll give you that back. So we pull one port. So remember when we pull them out the angle they went in, not perpendicular to the globe, and we press on the scleral tunnel as we do it, like so. And that closed.
I need to push. Really push me.
Got it. All right. He is now injecting the antibiotics in the decadron we discussed in the earlier case. There are those that are no longer use subconjunctival antibiotics, including Dr. Flynn, the world's expert in endophthalmitis. Maybe it's a bit superstitious, but having done 38,000 cases with only 3 post-op endophthalmitis cases, 2 were patient. One had a suprapubic cystotomy that was infected. One had bad oral sepsis. They both were bilaterally biome traction attachments. And a third one, also a diabetic, again, some 30 years ago, had quote, allergic to all antibiotics. All those patients lost their eye, and it was dramatic. So I've never had an endophthalmitis since then. That's 30, 35 years. And so, again, I use subconjunctival antibiotics. Unfortunately, the aminoglycosides, tobramycin and gentamicin, hurt because they're myelinolytic, and that's the pain you heard the patient express at the very end. And the retrobulbar block doesn't tend to block the inferior cul-de-sac very well, which is the pace that you normally inject these. So if you get a subconj hemorrhage, it's hidden under the upper lid. You always inject parallel to the conjunctival surface so that you can't penetrate the globe. Clearly, you don't want to inject gentamicin in the globe. So in this case, trade-off. Some people would have done a PRP. I don't fault them for that. But we know from the DRCRNet studies comparing laser to anti-VEGF compounds that anti-VEGF compounds have less complications, are equally effective, if not better. And so why not avail ourselves of that opportunity here to avoid destroying his peripheral field and his dark and decreasing his dark adaptation capabilities. So we do that by focally treating areas that might bleed post-op, as you saw me do. And again, diathermy would be a big mistake in any of those. It would lead to necrosis. So that's why I chose to use the hemostasis with the endophotocoagulator. And again, where some of those areas look more like large aneurysms, others look like NBE. But since the patient had a hemorrhage, by definition, it's proliferative retinopathy, not non-proliferative. Therefore, it was necessary to inject Avastin at the end of the case. Had we injected Avastin a week ago, we still would have injected at the end of the case because of the rebound phenomenon I described earlier. This patient was already pseudophakic, so we didn't enter into the discussion about the trade-offs about combined phaco. But I want to emphasize the point I made earlier. This widespread assumption that cataract always results from vitrectomy is simply wrong. It causes, as I said before, nuclear sclerosis progression, but I didn't say why and how. When you remove the vitreous, you permanently decrease the viscosity 800-fold. And as Einar Stephenson has taught us, oxygen diffusion has a viscosity factor in that equation. So there's marked diffusion. The Fick-Starling principle is where you can look that up, but in short, increased diffusion is the reason that you have partial pressure of oxygen increase. Others presumed it had something to do with ascorbate depletion or had something to do with infusion fluid. That's completely fallacious. It's 100% about having a partial pressure of oxygen in the eye of 12 millimeters of mercury higher for the rest of your life when you've had a vitrectomy. Nuclear sclerosis is an oxidative reaction. So in short, it does not cause de novo cataract. Vitrectomy doesn't. It causes NS progression. Do these patients a favor and leave their when they're still able to accommodate, leave their lens in place. I think this is very important for patients' utilization of their accommodation capabilities. We only have 6 or 7 minutes left. I think that in terms of training and learning, the most important steps that I can emphasize are, number one, move your hands incredibly slowly during vitrectomy. Why would you do that? Always cut vitreous free before you move the probe to a new location. Don't grab vitreous and pull back like you do in IA during phaco. So never pull back. Always use the highest cutting rates. Always use proportional vacuum, not 3D. Try to stay away from all these complicated modes and core and shave and blah, 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 and anterior and posterior. Just use proportional vacuum, highest possible cutting rates, and barely push the pedal down if you see excessive retinal movement. With membrane peeling scissors, as with even injection, always move your instruments as slowly as possible. Why is that? You're operating at great magnification, which scales up position. If you scale up position, what's the first derivative of position? Velocity. What's the first derivative of velocity? Acceleration. So scale down your velocity just as you've scaled up your vision with the magnification, particularly with the high mag we use now with these 3D visualization systems. The next thing that's very important is to think through not just a linear approach to surgery. We're going to do this, this, and this, but think through that often you find things different than you expected. You might create a complication. You might find a break you didn't anticipate. So having gas, laser, oil, various other instruments readily available in the room, and not, often some storage area, and having the staff and yourself ready to get these, but not to open excessive disposables and drive up the operating costs. It's very, very important. And then keeping your calm with the staff and even yourself so that you don't get angry, upset, nervous, allows you to do a much better job. I've been flying jets for over 30 years, and that lesson is learned over and over again in the cockpit, that anger, panic, disagreement between people leads to bad outcomes. So keeping your calm and pausing for a minute, saying, well, wait, this is different than what we thought. Oh, well, maybe let's take this approach instead of that approach. Very important way to do high quality surgery. I appreciate all those people who took the time to tune into this. I hope the surgery met everybody's expectations, and that the teaching did as well. And hopefully we can do more of this. I had the opportunity a week ago today. The Orbis plane came to Memphis, and we had a fundraising thing. The Orbis team did an extraordinary job of demonstrating the capabilities of the airplane to philanthropists, a whole team of people who love the airplane, love the team, love the mission, and are totally engaged in trying to help it go forward. Where was the airplane? At FedEx, one of our major benefactors at Orbis. So I want to thank Orbis, the entire IT team, as well as the leadership, Bob Rank and Hunter Cherwick and Danielle and others, and Dr. Haddad. It's an extraordinary team that has a great mission. I encourage all of you to participate both in the online learning as well as try to volunteer as your skill set and confidence is built up to go in missions and help Orbis. I think I better get on with some other cases now, but thank you again for everybody for participating.